I'd like to welcome everybody to today's webinar, Practical Tips for E-Prescribing Controlled Substances in Ohio. If you do have questions as we go through the webinar, please use the integrated questions feature in the GoToWebinar app. If you have a question for a specific speaker, please proceed your question with the speaker's name. If not, we'll just ask all of our speakers at the end of the presentation that question. If you cannot find the integrated questions feature, just enter it into the chat window and I'll make sure that your question gets presented. Handouts will be sent out shortly after the webinar ends to all attendees. We'll also try to make them available on our website. We are recording this webinar and we'll be posting the webinar to the CliniSync YouTube channel when it's been edited down and ready. So it'll give us a few days on that. With that, I'll turn it over to our first speaker, Ms. Cathy Costello.
Thanks, Scott. I really appreciate your assistance, without which this would not occur. Let me give you a little background. I am Cathy Costello, and as you know, we've been involved with both meaningful use and electronic EHR issues since the beginning of meaningful use 5 or 6 years ago. At that time, when we were just getting rolling, Ohio set up a task force to study e-prescribing issues, and this task force has become, over the years, it has addressed certain specific issues relating to e-prescribing. It was brought back together again early this year to address issues around e-prescribing of controlled substances, better known as EPCS. And at that time, a cross-state group from many different organizations and practices came together to work on the education part for training in Ohio. We were very pleased to have both Surescripts at the national level and the Ohio Board of Pharmacy at the state level as major players and giving us information on support and helping us to set up fairly substantial education information pieces for people out in the field. So today is really drawing together many of those same people and adding to it the expertise of people in the field and DrFirst, and we'll talk a little bit about that as we move from one provider or from one presenter to another. So as we begin, the first person who's going to be presenting is Ken Whittemore, who's the Senior Vice President for Professional and Regulatory Affairs for Surescripts. And Ken is, without a doubt, one of the primary forces behind EPCS at the national level. Surescripts has probably done more to spearhead EPCS than any other individual group or organization, and he has worked with many, many states in their efforts to bring this to people's attention and improve e-prescribing of controlled substances. So with that, I'm going to turn it over to Ken, and Ken, I'll let you go ahead and lay out the national framework and then what you're seeing so far in Ohio.
And Dr. Whittemore, you have been unmuted.
Well, thank you, Cathy, and thank you for the kind words directed toward Surescripts. So on the first slide that we are sharing here, this will give you a sense of what things look like with regard to EPCS at the national level. Just by way of background, it's been just a little over 5 years since the Drug Enforcement Administration issued its interim final rule to allow the electronic prescribing of controlled substances. And if you look at this graph, you can see that it was quite a while before there was any activity whatsoever. But over the last, say, year and a half, things really have started to accelerate. And just by looking at the table at the right side, you can see the extent to which that's been the case. In 2012, we barely saw 37,000 EPCSs cross our network. In 2013, that increased almost by a factor of 10. And 2014 continued to grow, and this year we actually exceeded what we thought we were going to see on the network. We had forecast originally for this year about 10 million transactions, and it does look like we're going to see about 12 million transactions by year's end. Other items to mention with respect to the national picture, as of the middle of September, when Vermont changed its regulations to allow Schedule II controlled substances, we got to the point at which every state allowed electronic prescribing for controlled substances for all schedules. So it is now universally allowed throughout the United States, and that we think is going to just further contribute to the growth of EPCS adoption and utilization. Next slide. One other thing I will mention with regard to the national picture, I imagine a lot of folks are probably aware of the fact that in New York State a law was passed a couple of years ago known as iStop. One of the requirements of iStop is that the prescribers in the state will have to begin e-prescribing both for controlled and non-controlled substances. Originally, the deadline by which they had to start e-prescribing for all prescriptions was March 27th of this year. For a number of reasons, the legislature in New York saw fit to push that out, but as of March 27th of next year, the electronic prescribing and EPCS will be mandatory in the state, with a couple of exceptions that are taken into consideration by the law. One of the reasons I'm sharing that with you folks, I know this is a Ohio-focused call, but I think it can illustrate the extent to which state-based initiatives can have a significant impact on these types of transactions. If you look at November of 2014, just a little over a year ago, in the month of November last year, we saw about 8,000 EPCSs traverse our network in New York. In November of this year, that number was well over 500,000. So that is exceptional growth in a 12-month period, and it is obviously directly related to the fact that both providers and pharmacies are ramping up in the state to comply with the iStop e-prescribing / EPCS mandate. Moving to Ohio, this is the latest information that we have through the end of November. As you can see from the graph, there is a very significant increase in the number of EPCSs that we're seeing in Ohio. The curve isn't quite as steep as it is nationally, but we wouldn't necessarily expect that because some states are ahead of the curve and others are behind it. But the direction is clearly, or things are certainly trending in the right direction, and we're seeing a good increase quarter over quarter. Next slide. This gives you a little bit more of a detailed picture of how things look in the state. If you look at prescribers, there are about just shy of 900 who are actively sending EPCS transactions in the state. About 1,600 of those who are active e-prescribers in the state do have the capability of transmitting electronic prescriptions for controlled substances, but they just haven't done so recently. So if you compare that with, let's see, I guess we don't have percentage numbers, so I can't really compare that well with the national level. If you look at the pharmacy status, nationally and in virtually every state, the pharmacies are well established with respect to their ability to receive electronic prescriptions for controlled substances. The national average is about 81%, so the pharmacies in Ohio are just a little bit ahead of that. And there are a lot of reasons around that, or reasons why the pharmacies are ahead of the game. Probably one of the most significant factors is that there wasn't as much to do on the pharmacy side to prepare to receive electronic prescriptions as there is on the EHR side, and I'm sure Dr. Kaufman will probably touch on that. But that's one reason that things stand the way they do with regard to pharmacies vis-a-vis prescribers. And by reference in New York, again, because of the mandate, we're to the point where about 96% of the pharmacies who are actively receiving e-prescriptions are also capable of receiving EPCSs in the state of New York. So again, that's something that even when you have a high percentage of participation, and mandate like this will drive it even farther. Last tidbit I'd like to share relates to this pharmacy figure. A couple of my colleagues here at Surescripts did some retrospective analysis, And they look back to the days when we were getting basic electronic prescribing going and what factors influenced the uptake, particularly on the prescriber side. And what they found was once in any area that you have at least 80% of the pharmacies capable of receiving e-prescriptions, that's when things really started to take off in terms of physician adoption. And it's kind of intuitive that, you know, once a physician feels comfortable that just about any pharmacy that they would want to send an electronic prescription to is going to be able to receive it electronically, that they might be more inclined to adopt than if they didn't think that was the case. And clearly here nationally and in the state of Ohio, we've exceeded that. So hopefully physicians now who are interested in engaging in the EPCS in the state of Ohio will feel pretty comfortable about the fact that just about any pharmacy that their patient would want to have them send an EPCS to would be able to receive it. And I think that's probably the last of my slides.
Thanks, Ken. We appreciate that. With that, we're going to turn to the state level and get input from the Ohio Board of Pharmacy. Joann Predina is the compliance specialist with the board and has worked pretty continuously, actually even before meaningful use, with vendors on the issue of e-prescribing and trying to improve the system both at the state level, clearly to feed into our state regulations, but also to give input at the national level. And we've been very fortunate to have her as a good partner to help us work through the issues related to e-prescribing of controlled substances and clarifying for both pharmacists and physicians and other prescribers as to what it is that really needs to be done, technically speaking, with your EHR system in order to have EPCS. Because there is an issue, there's a difference here between, as Ken pointed out, the DEA regulations, which are the governing regulations for the electronic systems as to what needs to be done, the state regulations, and then the separate thing, meaningful use, that we will talk about after Joann gets done. But with that, I'm going to turn it over to Joann, who can give us a kind of specific picture of what she's seen in the state, issues that occur around the state regulations and implementation of DEA, and then just any general thoughts she has related to this. So Joann, go ahead.
And Ken, I have placed you back on mute, and Joann, you have been unmuted.
Thank you. As Cathy said, we've been working on electronic prescribing with OHIP and other agencies to get this rolling in Ohio. I've been the selected person that works with all the inpatient facilities, and I do about 95% of the outpatient types of what we call prescription writers. This year, with the ICD-9 to 10 switch and Meaningful Use 3 coming aboard, hot and heavy, and early in the year people were turning on EPCS or at least getting set up. Then to my perspective, it came to a little bit of a halt while we were trying to get the ICD-10 codes and meaningful use in place. And now it's started to pick back up where companies are adding the EPCS systems to their existing prescribing system. So what I'm finding and what we're still looking at is one of our codes talks about if it's an EPCS approved system and you're using DEA level signature for all prescriptions, then that would be an accepted system in Ohio. And what we're finding on spot checking is that some of the systems are not including the Ohio requirements, which are above and beyond DEA's requirements for their systems. So even if you're applying the DEA level signature to all your prescriptions, once in a while we're finding that the conversion dropped the Ohio requirements to submit a credential in the prescriber suffix field. So we need to know if it's a doctor, a veterinarian, a nurse practitioner, the MD, DVM, those types of credentials need to be transmitted in a very specific field. The certificate to prescribe number, if you work in Ohio, you know that's a unique Ohio thing for mid-level practitioners, the nurses and assistants. Once in a while, that'll be dropped from a system because DEA does not require that, but Ohio does. And the agent transmittal is required in Ohio. It should never appear on a DEA script, but for all others it will if there's an agent involved in the transmission. So we are still spot checking for those 3 requirements on an XML data transmission sheet that's coming from the transmitting system to make sure that those are picked up in the controlled substances as well as the non-controls so they weren't dropped. And the final feature is that positive ID piece. People misread the rule. They think if they have EPCS signature, they're fine, but they forget to put it on all the prescriptions. So we do go back and do spot checks on that. And the other thing I'm finding is partnering with a major system, and Dr. Kaufman will be on the phone, and DrFirst has partners that we work with as well as some other companies. So if you look at our website and names are printed, it might say DrFirst, but that doesn't necessarily mean every DrFirst partner. So we have to go back and with the help of Surescripts, we're identifying some of those companies that are working in Ohio that should not be because they were never really approved by the Ohio board to do so. We're working with DrFirst and some others that do a lot of partnering types of situations. So that's where we are now, at least from the board perspective. I have had a few what I call, major forward movement when some of the hospitals, even out of state, that the main hospital might be on the border out of state and they have doctor's offices in state, and when they're turning on EPCS, they're turning it on for everybody, including who's in Ohio. So that's a really nice thing to see. And then they call and we make sure that positive ID is still in place correctly here. So we're seeing movement much more now because ICD-10 is sort of hopefully done and MU3 is well underway.
Thanks, Joann, for the summary. I have a couple of questions, or I would love for you to clarify. I know that when we had started as a group, as a state, to look at this almost a year ago, one of the biggest issues that we found that was acting as a block to EPCS in Ohio was the mistaken belief by many pharmacists that the Ohio Board of Pharmacy said it was illegal to electronically prescribe controlled substances. So if you could just verify the information that you have given time and time again, that this is not going to result in having their license revoked.
It will not, it should not result in any kind of revocation. The scripts need to come to the pharmacy legally, and most of my calls come from staff pharmacists because it's poor communication through corporate, letting them know that the systems have been cleared for EPCS and they're able to take controlled substance prescriptions. And I still get probably 2 calls a week from someone who's just not sure. They're automatically coming in. They didn't even know why. So I think we've put out plenty of information, and Cathy and her group has done the same. I think it's just a few stragglers at this point after our last push that are afraid to take them because they haven't been formally told they can. And then we assure them that they can.
Okay, and then the other thing, Joann, that I think is good clarifying is because there's really 3 places where certification issues come into play, DEA, Ohio Board of Pharmacy, and meaningful use. I think it's worthwhile just pointing out to people that the Ohio Board of Pharmacy is not the certifying agency for DEA or for controlled substances. You want to mention that and talk about that?
The EPCS approval certification process has nothing to do with the Board of Pharmacy at all. All we're doing is saying if you use that exact signature that they've approved, then in your own audit, then that signature may be applied to all the other prescriptions and it would be considered a legal signature in Ohio. But we have nothing to do with the DEA audit in any way. Our approval is separate.
Okay, thanks, Joann, so much. I think that you really clearly summarize the role of the Board of Pharmacy, and I would encourage anyone who has a question about this to reach out to Joann and the board, because they are both extremely knowledgeable and extremely helpful in this area. So with that, we're going to move into the question of meaningful use and how it plays in with the whole e-prescribing of controlled substances and changes that have come about in the last few months in this area. As you all know, e-prescribing generally was part of meaningful use from the beginning. And we had reached the point with stage 2 before this last set of regs 2 months ago came out, which, by the way, are final today, that the physician or EP prescribers had to meet 50% of their prescriptions had to flow electronically, and for the hospitals, should they have chosen to do it at stage 2, it was 10%. But at that time, at stage 2, which was the 2014 standard, controlled substances were specifically excluded from the calculation of e-prescribing meeting the meaningful use threshold. So it just was taken out of the mix totally. So for, especially in your areas of pain management or surgical, where you might have a very high level of controlled substances prescriptions, what you'd see is they had very low reporting numbers generally, because those continue to be handled through the paper form. What we found in the rules that were put out by CMS in October, and as I said, final today, there was a change in this whole approach as to how prescriptions were to be calculated. And we moved away from the concept of legally prescribing to the question of permissible, that what was not counted before, because the controlled substances e-prescribing was not necessarily recognized in all states. It wasn't counted before, but now, as Ken told you, all states recognize controlled substances e-prescribing, so the language in the regs was changed to permissible prescriptions. What is permissible? And that change in the 2015 regs continues on into stage 3 with the same terminology of permissible. Now, when you move into stage 3, whether or not you're doing stage 3 in 2017 or 2018, the reporting level will stay will not increase beyond 60%, and this was in part due to allowing systems and providers to upgrade to a new system. They did not want to push the number of prescriptions that were done electronically to too high a level with the possibility of patient safety issues. So that's why you see it stay at 60% generally for e-prescribing. But as you get into the question of whether or not controlled substance e-prescribing is required under meaningful use for stage 3, it's a very interesting analysis. And I would say that you end up with the approach that it is not required, and I'll walk you through that, but strongly recommended according to the language of the regs. This is just a summary of the EP measure, which is, as I said, 60%. And for the EH measure, it's 25% for stage 3, moves from 10 to 25%. For hospitals, you know that you were exempt from e-prescribing for 2015 and 2016. If you have not developed your plans for e-prescribing, you do need to have that in place by 2017, which is the perfect opportunity to analyze your workflow as it pertains to controlled substances at the same time. The issue in the regs were very, shall we say, confusing. We all kind of shook our head and laughed about it when we saw it, because the proposed regs continued to make the concept of e-prescribing of controlled substances a permissible but not required activity. And over the past several months, and as Ken pointed out, really just in 2015, you had all states finalize the the acceptance of e-prescribing of controlled substances, CMS took a look at this as they finalized the regs, and they put in this language, and I'm not going to read the whole thing to you, but I do want to read the important sentence or two so that you understand the issues involved here. So as they had proposed it, they were not going to require e-prescribing of controlled substances. And so what they said for 2015 to 2017, while we intended to maintain the option of including it, based upon public comments, we are modifying this policy that the inclusion of controlled substances should be required where it is feasible to electronically prescribe and where allowable by law. Well, as Ken told you, it's allowable everywhere by law. So how hard and fast is this? You go on to the next sentence in the regs, and it says, therefore, we are changing the measure for this objective to remove the language regarding controlled substances. Instead, we are adopting permissible prescriptions for stage 3 that providers may include electronic prescriptions of controlled substance in the measure. And I am not kidding you. That is exactly what the reg said, may. So clearly when they were doing an edit, either they had a policy dispute or they just missed it in the edit. But as you come down to it, as we read all the regs together, I think the correct interpretation is that e-prescribing of controlled substances is not required at this time under stage 3. And the reason we say that is because there is no reference to e-prescribing of controlled substances in the certification standards for stage 3. So your EHR system is not required to be certified to do controlled substances e-prescribing. So it is not required but strongly recommended. I think the language that CMS puts forth in the regs clearly shows that they are moving in the direction of requiring it at some point. So I would suggest that organizations and practices that have not explored this yet with their vendor really should move ahead and look at this as trying to establish a timeline when you're going to want to adopt e-prescribing of controlled substances. So the short answer is you don't need to be doing it right now. You can do it if you want and include it for purposes of meaningful use. You are going to want to plan on it as you move ahead because every year CMS has the option or opportunity to update those regs and can drop in some required language at some point. So just again to clarify, the certification through DEA is the certification that controls what the pharmacy system must do to receive, what your EHR system must do to send, and how to handle the identity proofing of prescribers so that it is clear that there is dual authentication and that the person is who they say they are. And I think that that's probably the best segue into what Dr. Peter Kaufman from DrFirst is going to be able to show you about how to handle the dual authentication piece for identity proofing for e-prescribing of controlled substances. And for those of you who are not aware, DrFirst, it's an interesting picture nationally because we have hundreds of EHR vendors, and for meaningful use, they're required to be able to do e-prescribing if they're a completely certified system. But the backbones and guts of that e-prescribing system for a lot of vendors is DrFirst. And so as Joann referenced, there are issues as far as the marriage of individual systems with DrFirst, but DrFirst is the one that actually produces the information and handles certification and stuff. So Dr. Kaufman, with that, let me turn it over to you. I think you'll probably have the best view of the dual authentication that's required.
And Dr. Kaufman, you have been unmuted.
Thanks very much, and my mic is showing that it's picking up, so I hope you can all hear me fine. Thanks for inviting me to this. I have a lot of love for Ohio. My son lives in Cleveland and spent a lot of time there. Can we go to the next slide? I'm going to talk about what's required for sending controlled drugs on the physician's side. You have to go through 3 steps in order to send a controlled drug that you wouldn't have to do in 49 states in the District of Columbia for legend non-controlled drugs. Although in Ohio they do want a 2-factor authentication of sorts and are willing to allow a workaround of printing it out and signing off on the list of prescriptions that have been sent, but really they want 2-factor authentication, and the way it's described is how many times people have seen somebody write their password on the bottom of their keyboard. It's not a very good security for prescriptions if the password's written on the bottom of the keyboard, so they'd like something a little stronger. But in any case, what the DEA is requiring is, and that, can somebody move the mouse on the keyboard so we're not covering up the words there? The slide mouse.
Oh, sorry.
The first thing is identity. First thing is identity proofing. You have to prove that you are who you say you are. And you can do that a couple of ways. One way is to do it online, where you're providing out-of-pocket information, such as what your mortgage payment is and how much you owe.
Dr. Kaufman,
Sometimes it's a little difficult. Yeah.
Yeah, but your audio is breaking up just a little bit.
Okay.
Yep,
I'm watching my microphone and it looks like it's working okay, but I will make sure that I hold it near my mouth. So for the identity proofing, you can do it online with out-of-pocket information, or thanks to a couple of us at DrFirst meeting with people at NIST, you can also do it at a hospital at which you have privileges, because we showed NIST, who wrote the regulation for identity proofing, what a provider actually goes through to get privileges at a hospital. So that you can go to your hospital medical staff office and they can also provide identity proofing for providers. The second step is logical access control. Suppose you have an electronic medical record and you've been identity proofed. You have to attest to that electronic medical record that you are approved for writing controlled drug prescriptions with that program. So that's done with 2 people. It can include the provider who's getting access, or it can include 2 other people, one of whom has to have been identity proofed and have a 2-factor authentication. So you get identity proofed, you are who you say you are. The system gives you permission to use the system, and then the third thing is 2-factor authentication when you send a script. And let's go to the next slide and talk about 2-factor authentication. 3 factors. Those are, can you click so we see the text on there? Something you know, which would be a password or a PIN code that you put into a field on your computer screen. Click again. Something you have, such as a hard or soft token. What we show on the left is a hard token, which shows a 6-character number that you would then type into another field in the computer. On the right shows a smartphone that also shows a 6-character number, and those 2 either one would be acceptable. Many of our users have one of each. If you're writing on a mobile device, you can't use the same mobile device for your soft token, that one on the right, or it can be a smart card. It can be something like a crypto key that plugs into the computer, into the USB port, and encrypts the message. But it's basically something that you have that works in conjunction with one of the other factors, such as something you know. The next, click again, and you see something you are, like a biometric, a fingerprint, or an iris scan. So that you could use a PIN code and a fingerprint, or you could use a hard token and a fingerprint, or a fingerprint and a PIN code, or a fingerprint and you could use any of those, any 2 of these 3 for your 2-factor authentication. Next slide. So this shows a typical screen that you'd go to for signing. The DEA is extremely specific in things that need to be on this screen. So this screen includes all of the factors the DEA requires. The bold text toward the bottom by completing the two-factor authentication protocol, etc. That is word for word specified for the DEA. It has to show on the screen you're signing for. You can sign for multiple prescriptions for the same patient, but if you're signing for more than one patient, it has to be signed individually. You have to re-sign for each patient. And on this screen, it's set up for the two factors of a passphrase and a PIN code from an OTP token. OTP is one-time password. That's the number that changes every 30 seconds on the previous slide in the middle there. So you'd put those two in, and what's not showing on the screen, unfortunately, just below the question mark to the right is a little button that says cancel, and just to the left of that is a grayed out button that says send.
Okay.
Is for the user. What? Can you hear
Dr.
me?
Kaufman, can I just ask you to address, since you really probably have a better view than anyone in the country of how this is working individually for individual physician practices, can you talk about how various EHR vendors utilize the dual authentication and then issue any issues or acceptance level that physicians have relating to small practices doing EPCS?
Sure. Let me just mention the one last thing on this slide. The checkbox next to where it says Percocet has to be manually checked. It can't be automatically checked. Every EMR that I know that's doing two-factor authentication is either using a hard token with a one-time password and a PIN code, or a fingerprint and a PIN code. I don't know any company that's, if Joann wants to contact me later and tell me that some of the other companies are doing something differently. But as far as I'm aware, they're doing that, and most have a signing screen like this, although sometimes it's integrated right into their prescription process and just shows that that statement on the screen. We have had very good response. It looks complicated when you're just looking at it, deciding you're going to do it, but it actually works very quickly, and you're still using one system. You don't have to pull out a pad for your controlled drugs. You're writing your legend drugs, you write your controlled drugs, you sign off on everything, and then you just have to put in the DEA required two-factor authentication signature for the controlled drugs. In Ohio, I know we do, and I'm sure some of the other companies do, have the ability to use this two-factor authentication you've obtained for EPCS for your legend drugs as well. Now, the way we do it is you don't have to go to the signing screen. We do it right on your regular e-prescribing workflow, where you just, in addition to putting in your PIN code, put in your OTP 6-character number, and then you don't have to print it out and sign off on the sheets every couple of days. You're doing it the way that Ohio really designed it to be done. But we did a study in Western New York, in Western Massachusetts, and it was remarkable how positive all of the participants in the study were. We thought it was a little bit of extra workflow, and people would at least have complaints whether they used it or not. But we found that the prescribers were very happy to use it and found that it was not intimidating, although almost all of them found it intimidating until they'd used it. So go ahead and give it a try. It's a lot easier than it looks. And I think that's my last slide.
Dr. Kaufman, can you talk just a minute too about, you had started to say that physicians can get identity proof through the hospital where they have medical staff privileges. If they do not go that way and they do the independent identity proofing, how many companies are there that do that? How would a practice get in touch with them? And any other suggestions you might have about moving ahead with that?
Because the identity proofing has to be tied into getting your token, because once you're identity proofed, it doesn't help if you get a token that isn't tied to that identity that just got proofed. So that because they're tied in together, it's going to come from your vendor. So we will direct you from our website to our identity proofing company, which is Experian, and you go to their site and do it. Mark could probably tell you. But each vendor is tied with their own people who do the identity proofing, and then as part of that process, you receive your token. In our case, you receive it in the mail to your home address, and that proves that you are the person that is being billed at that home address. You can also receive, for a soft token, you just download that, you can receive a to something, and then they send a text message to your cell phone. Well, we can do a text message or a verbal message to a phone as long as it's billed to your home address. Because of the way the regulations are set up, we can't do something that's billed to a business. So if you only have a cell phone and it's paid for by your practice, you're going to have to get something mailed to you as opposed to messaged to you either verbally or by text message. Did that answer your question?
That's very good. I think very helpful. So your first message, the ultimate message for physicians who are doing this individually, is to contact your vendor and find out who they're using so you can coordinate with them.
Right, and because of...
Dr. Kaufman, I think you're breaking up, so if you could just repeat yourself, that'd be great.
Because of New York requiring e-prescribing controlled substance as of March 27th, at least every vendor that has any users in New York either has it or is in the last stages of getting it ready. I know my vendor does not yet have it, but they're actually going through testing now, and they'll have it very soon. Okay. They're a DrFirst partner, but because, like they said earlier with Ohio, they're running for New York State, so Ohio will benefit.
Well, thank you for your comments. As I said, I think DrFirst is probably most knowledgeable of anyone about the small physician market on this. And with that, we're going to move into a general panel discussion by several physicians, Dr. Kaufman being one of them, who have been involved in the whole adoption of e-prescribing of controlled substances. Dr. Walt Reiling is the CMIO for Premier in Dayton, and Dr. Stephen Beck is the CMIO for Mercy Health, headquartered in Cincinnati. And I think both of them have done a fabulous job in getting their systems ready for e-prescribing of controlled substances, but we thought that you would appreciate their personal perspective, both of them being physicians, and also a little bit about what goes into setting up a hospital system to do e-prescribing of controlled substances, and in their cases working with the vendor that is the largest vendor in this state, and that is Epic. So with that, I think Scott has
yeah, Dr. Reiling and Dr. Beck and Dr. Kaufman, you are all unmuted.
So with that, Dr. Reiling, do you want to start and kind of give us your view of what you went through to get Premier up and going on EPCS and where you are now with it?
Sure. So just a little background. We have been up on Epic at Premier since 2006 and using e-prescribing in general probably since around 2008, I believe. It's been so far back to not remember exactly. So we started looking at the e-prescribing of controlled substances last year and actually began deploying it in our practices in first quarter of this year, and I think in February our first site went live. And we had a couple of issues that we had to work through. We using the dual-factor authentication that we have in Ohio was already somewhat helpful for us, but the requirement from the federal level of having FIPS-compliant hardware caused us to have to replace our biometric device, which is a fingerprint reader that we use with the second factor, and we use a password as our first factor for the two-factor authentication. So we had to go through and replace all of our fingerprint readers, which was a little bit of a extra step that we needed to take. It was a very quick rollout for us on our ambulatory practices. We do not currently do e-prescribing on the inpatient or ED environment, but we are going to be doing that starting next year. We have about 350 physicians in the ambulatory environment using the e-prescribing of controlled substances at this time, and it was really one of the few IT initiatives that we rolled out where we had an appreciative audience. The physicians, once they knew that we were putting this out, were clamoring to get a hold of it, and really they very much like using this and eliminating the dual workflow of sending some of the prescriptions electronically and then having to print and sign by hand some of the prescriptions when they were sending them for the patients. I've used it myself, and it really has been very nice to stick with that one workflow. And as Dr. Kaufman pointed out, you do have the extra screen that pops up for the controlled substances that in our EPIC environment looks very similar to what he showed from the DrFirst environment. But it really is pretty seamless to do and very easy and very much a physician satisfier.
Dr. Reiling, and I know you haven't implemented your inpatient e-prescribing yet, and I don't know, Dr. Beck, if you have, but if one of you could address the issue that I know we get asked frequently, if a physician is doing e-prescribing within a facility and also within their office practice, do they need two separate identity proofing different tokens, or can they go with one token for both, or how does that work?
Well, I can address that. This is Dr. Reiling again. In our system, we will be using a single situation across our environment because we are on one instance of EPIC across the spectrum of care. We will not need to use something separate. I do think that in a situation where you would have a different EMR for the inpatient environment and the office, it may not be possible to use a single token, for instance, across the two environments. But Dr. Kaufman or Dr. Beck, if you know differently, go right ahead and jump in there.
No, I would agree with you, Dr. Reiling. So we have not yet rolled out to our inpatient providers, but we're in the same circumstance where we have a single instance electronic record across our enterprise, and are going to use only one identity matching one token. I think I've actually talked to some of the vendors that do token management and really brought this issue up about 2 years ago, that none of the companies really have done a good job of being able to use or develop a process by which you could have a single token across a community. So within 100 radius miles of our main office here in Cincinnati, we have 9 health systems. They're all using the same electronic record, but different instances, and so you would, in theory, need multiple tokens for the multiple systems. And I think it really, it behooves the vendors to, I'm not talking about the EHR vendors, I'm talking about the token vendors, to look into solutions. I realize that may be more challenging perhaps with fingerprint, but with soft tokens and other token devices, it would seem like a logical approach for communities that really over time will have more and more electronic records with different credentials.
I think
that's a great point. And am I on mute? Okay. That's a great point, and actually there are systems that are working on doing that now. There's identity coalescence projects. There's something called the IDESG, the Identity Ecosystem Steering Group, that is working on that, and we have a product in development called InfinID that will allow identity to be passed across multiple platforms so that you'd be able to get down to having one token that would work on multiple systems. Nobody wants a keychain full of tokens, or one for their office, one for the practice they moonlight out, one for one, full of these things. There needs to be an answer to that, and there are lots of people working on that. That's a great point.
So this is Stephen Beck. If you don't mind, I'll just give you a little background about what we've done at Mercy Health, and then that made me lead into further questions. So we started our electronic record journey across our enterprise in 2010. on a single instance, EHR, ambulatory and inpatient. We are nearly done with our inpatient rollout, having hit our 21st hospital about 10 days ago. But we started day one with electronic prescribing with all of our providers. And as EPCS was evolving, we were keeping close tabs on it, and just as similar to Premier, we were looking into it, and frankly, we were waiting for some of the maturity of the pharmacies to make sure they were caught on. It didn't make much sense for us to try a heavy rollout and then find out that half of the pharmacies wouldn't accept prescriptions. So we started our initial pilot on this early this year, and then a full rollout this fall. And we're up to about 400 providers or so. We're well over 5,000 completed orders as of the end of November. We likewise, because of the FIPS compliance issues, and for those on the call that aren't familiar with the Federal Information Processing Standards, it is important to look into that. We had been using tap badge readers, which were not FIPS compliant, and so we transitioned our providers that were interested in EPCS to soft tokens as the preferred method. We also offered hard tokens. There is a fee associated with those, and we have used hard tokens in the past, but found that the providers, most of our providers really preferred the soft tokens. And the advantage to us was the providers that went to multiple sites or went to remote sites and might need to send something, even as much as a home visit, for example, or at a nursing home discharge where a provider wanted to prescribe something electronically, the soft token made a great deal of sense for them. So it's worked out really well. Because of the cost of the tokens, we've done this only with interested providers, although we've really tried to encourage them to do so. But of course we know that some of our providers, pediatricians or others, may rarely, if ever, prescribe controlled substances. So we just wanted to be mindful and do it in a cost-effective way. So there's been a real excitement around this, and I'll echo what's already been said, is our providers that have used it and used it a lot really love it. And it does give them a lot of freedom. I think there were a lot of concerns in the beginning about how that would affect practice, would it slow them down, but it really is safer. It improves quality, it decreases diversion, all those things that really make it much more efficient for patient care. The example that I like to always go through, because it rings true to most of us as adults and parents, is kids or adults with attention deficit disorder and are on those types of controlled substances. Really doesn't necessarily require a visit every month, but does require a new prescription every month. And so this makes it easier for patients.
Maybe in college too.
Yes, makes it easier for college. Makes it easier for patients to, pick up their prescriptions and really again makes for a much more efficient practice and much more efficient and quality-minded care.
Can you, either Dr. Reiling or Dr. Beck, can you talk at all in your community, or has there been general acceptance and understanding by the pharmacies now? Do you feel like you've reached that critical mass where that's not an issue? It's really just getting your physicians educated as to what needs to be done?
Yeah, this is Dr. Reiling. When we first started bringing this up in probably the latter part of the first quarter of this year, we were getting some pushback, some pharmacists who would call back and say we aren't able to accept these, they're not allowed. Most of the time it was from a chain pharmacy where they were and they just didn't know it. But that has pretty much cleared up, and I would say at this point there's very, very seldom ever any issues, and the acceptance is very good.
And I would echo that. This is Steve Beck, that we've really not had ongoing issues, a few initial issues. We do have, I know this is focused on Ohio, but we have facilities in Kentucky, and it is a much bigger problem down there. We're nowhere close to 80% of the pharmacies are enrolled. It's actually a fairly low number, especially in some of the smaller communities. So that has been a challenge in that state. So we're really in a great place in Ohio, which is great news.
Thank you, Dr. Reiling, Dr. Beck, and Dr. Kaufman. And with that, I'm going to turn it over to Scott. We've had a number of questions come in, and we'll read through them, and we'll unmute all of our speakers so that they can respond. So with that.
All right. All speakers have been unmuted, I do believe. Yes, they have. And we'll start with the first question. And this one probably is geared more towards Joann. It says, do providers have to e-script controlled substances in Ohio, or can they continue to write out and have the patients pick up the script and sign for it in the office? Or are there plans in Ohio to make EPCS required?
There are no plans that I know of at this point to make it required, and physicians can still write a prescription just like they always did. The EPCS is basically an additional way to prescribe. So the only thing that's really been stopped is e-to-fax, where it goes from the doctor's computer to the fax machine in the pharmacy. Traditional fax, where he signs it in ink and puts it in a traditional fax machine, is still permitted. So it's just an additional method to help.
Except not for Schedule 2. You cannot hand sign a prescription and manually fax to Schedule 2,
well,
except for 3 cases.
Right, correct. I'm sorry. I always forget I have a different audience here. Yes, there are certain cases that you can and cannot, so you have to read the reg on which times you can put a C2 in a traditional fax.
Okay, next question. This is probably one for you. What are the 3 main items the Ohio Board of Pharmacy needs in the XML file for EPCS not to error?
The CTP number, which is the Certificate to Prescribe number, and that would be placed in the license ID loop. It's a special state license code that's in the ID loop. We need the credential in the name suffix field, and not for EPCS, but for all others, we need to make sure the agent is still transmitted.
Okay, next question. Again, this one's for Joann. Please review the 3 criteria the board looks for when verifying an EPCS system.
It's a little bit more than 3 that we're looking for, because we're looking at the EPCS system for, again, the CTP number and the credential, and then we make sure that if you're assigning that signature to all the other prescriptions that are non-controlled, that it maintains the same standard and the agent name, and then we can sign off on that system.
And just to be clear, so people understand, Joann is not saying that the Board of Pharmacy certifies systems to meet the DEA regulations for EPCS. That is done in a totally separate track. What Joann is referring to is whether a system that does EPCS continues to meet the Ohio Board of Pharmacy standards for any prescription transmission.
Okay, Joann, yet another one for you. If our EHR has been previously approved for e-prescribing, do we need to contact the board for system review for EPCS?
We suggest that after the EPCS is done, we take another tap at it to make sure you didn't lose the CTP number, the credential, and to make sure positive ID was maintained for all the other prescriptions and the agent name is still transmitted. So we're asking people just to call in and we do a little tap. For example, at Mercy, because everything is really the same throughout that hospital system, for my concern, once I can do one Mercy, we do them all. It's not necessary for every hospital within a system to call, but if it's all done like Dr. Beck's doing it, we can handle it with one phone call.
Okay. This one is probably for Cathy and Joann. Any comments about ORs being approved for the specialized registry measure for the meaningful use public health objective?
Right now, the way that the public health objectives are approved in the state of Ohio is they go to the Office of Health Transformation, to the Ohio Department of Health for review and recognition. The Ohio Board of Pharmacy really doesn't get involved in meaningful use and what is acceptable in the state other than to provide technical background on it. And it is my understanding at this point in time that Ohio has not recognized ORS as a meaningful use recognized specialized registry. That does not mean that there are not other state laws that require ORS reporting.
Next question is, will slides be available for download after the presentation? The answer is yes, we will be sending a copy of the slide deck to all attendees. Next question, in Ohio, if doing two-factor ID for sending EPCS, do we no longer have to have the hard copy report of all scripts that were sent electronically?
This is Joann, that would be mine. And the answer is it depends on your system and how you're using the signature. You may still need to include the paper report if you cannot get the EPCS signature on all prescriptions.
Next question is for Dr. Reiling. What dual authentication solution are you utilizing?
So for Premier, we use the combination of the password and the biometric authentication through fingerprint through Imprivata as a partner with Epic. We also have the availability for a soft or hard token for a backup process when people are either in a location where they don't have access to the fingerprint reader, or in cases which happen extremely rarely, where they don't have reliable use of the fingerprint reader.
Next question is, I believe, for Dr. Kaufman. What is the cost range for physicians to add authentication to do EPCS?
I'm guessing on this because I don't know exactly, but it's under $100 a year. But I don't know how much under $100 a year it is.
We've heard anything around $75, $85, $95, but I would agree that the most common figure we're hearing is under 100.
Next question. Can all schedules of drugs be e-prescribed under EPCS, or are there some restrictions?
Ken, do you want to take that?
You can't prescribe. Oh.
You can go ahead and let Peter was on the way to explaining it, so
Oh, okay.
I'm sure.
You can't prescribe Schedule 1 in any case, but otherwise all schedules can be prescribed electronically.
And Joann, are there any restrictions specific to Ohio?
No, not for EPCS. It's all DEA's regulations.
Next question is, how does an independent provider become EPCS approved?
Joann, are there specific things for Ohio for that?
Well, the system has to be approved for EPCS and the non-controlled drugs. So it usually starts with us, where they make sure that they're on our approvable list. That's posted on our website. And then the EPCS generally comes after. Sometimes they're all ready to go when they knock on our door, and they're both in a different state. They're ready to go with EPCS and what we call EPTS, the non-controlled. So sometimes they come ready to go, and they just have to add the Ohio requirements, and they can go from there.
And what I'd say is, for those of you who haven't utilized Surescripts' website yet, they have a whole website devoted to EPCS, in which one of the slides is a listing of all the vendors that have EPCS certification under the DEA. You can check for your vendor there. Obviously, you need to check directly with your vendor to get an update on it. But if you're just looking to see if they are already in the process, I think Ken's group updates that regularly, like every couple of weeks. Right, Ken?
Actually, we update it probably every several days.
Okay. Okay, but there's actually a couple things that are on that website that I would encourage you to look at. One is the list of vendors, one is the list of pharmacies that are certified to receive, and one is a list of physicians that are identity proof to send.
Next question is for Cathy. To start including EPCS in meaningful use ERX reporting, does one need to have this implemented at the start of the reporting period, or can it be added during the reporting period?
No, I would say it could be added during the reporting period because the underlying percentages are driven by less than EPCS, and if you add that, you can continue to report during that reporting period.
Next question is for Ms. Joann Predina. For clarity, if the EPCS signature is on the prescription, then the hard copy is not required, correct?
The hard copy is not required and should not be handed to the patient. It's an electronic prescription, and that is the single issuance on the prescriber's end. For the pharmacist on the phone, we're still asking that the hard copy be, that your data that you receive in the pharmacy is printed to create the hard copy for your pharmacy file. But on the prescribing end, there should never be a time that a patient gets a dual prescription. It's an electronic send, and that's it.
And what we have is the last question is, oh, nope, just had another one come in. So, can security questions be used for dual authentication with EPCS?
No, this is Joann. They cannot. That's a state authority for non-controls, but DEA will not accept that.
Okay. Next question. Is a nurse allowed to input the ERX in the system and then the provider actually e-prescribe it? In other words, can the nurse set up the RX for the provider?
Dr. Kaufman, you want that one?
Well, this is Ken. I'll jump in. It is permissible for an agent to input the prescription, but it has to be the prescriber themselves who electronically sign using their two-factor authentication and transmit it.
And that's
the way you wrote the regulations. That information on the prescription has to be showing on the screen at the same time that the doctor signs it. So it can't be scrolled off the screen for the doctor to be signing something they're not sure what they're signing.
Yeah.
Or prescriber.
Okay, we have a follow-up question for the previous question, which was for clarity, if EPCS signature is on the prescription, then the hard copy is not required. The follow-up question is that they were referring to the daily report of scripts that is printed out at the end of the day. Is that still required?
It may be, depending on the system. That's why we have to go back and look at them. If we've said EPCS can be used for both, then no, you don't have to, because you're signing them with a legal signature based on DEA. But if it's not capturing all the information that we need, and positive ideas assigned to phone orders, they're also assigned to in-clinic orders, we need to look at all that with the system. So the answer is maybe. You may still need that end-of-day report.
And that was our last question.
Thank you all so much, and many thanks to our presenters who I think did an excellent job in giving you all a view of how EPCS is coming into Ohio. So with that, just a quick reminder, this will be available on YouTube, and we have handouts that will be sent to everyone participating later this afternoon. And if you have any other questions, feel free to contact any of the presenters. Their email addresses are on the slides. So again, thank you all and have a great day.